everyone, and welcome to Autism Hope Library. I'm really excited over our next guest. I met her several years ago, and she is a wealth of knowledge. You are going to be so excited. Dr. Cohen is here today, and we're going to be talking about what is audiology and what is an audiologist. I know a lot of people don't know the differences and what exactly they do. You know it has something to do with ears, but we're going to dive in, and you're going to really hear what it's about. So welcome, Dr. Cohen. Thank you for being here today.
Thank you, my darling. Thank you for the invitation. I'm so excited to be here.
I am so excited as well because I know so many of our kiddos, and when I say kiddos, and I say this every interview, it doesn't matter if you're 2 or 52, you are somebody's kiddo. So I know so many of our kiddos out there are having, sensitivities, and we're going to dive into that and why we need to find people like you that can really help us. So before we go over to that side, let's talk about what is audiology and what is and who is an audiologist? Like, what is the difference?
Okay, so let's start that. That's a great place to start. So audiology is the science of basically hearing and understanding. So our ears are made of 2 major organs. There's one organ which is called cochlea, which is our organ of hearing. And then we have semicircular canals, which is our organ of balance. So audiology is the science that brings these 2 organs together and talks about the health of our hearing, understanding, and balance. Now, audiologists are of 2 kinds. Before year 2000, most of the audiologists hold a master's degree in audiology. So they had to go to school to get their bachelor's, and then it was a 3-year program for master's. After year 2000, we switched to audiology as a doctorate program. So a lot of those who used to hold a master's degree went back to school, either distance learning or in person, and studied for another 2 or 3 years, and they became doctors of audiology. But all the new students after that year, they had to actually get accepted to a Doctor of Audiology program. So now any Doctor of Audiology program is a 4-year program in person that students basically learn about the anatomy of the ear and the balance system, the brain, how the brain works in processing of the speech and communication sounds, and what do we do for treatment if there is a disorder. So that's what is the science of audiology and audiologists. Now, I have to make an exception here, a category that now we have audiology aids and we have hearing aid dispensers who are doing audiology work too. These 2 categories, basically for hearing aid dispensers, those are people who basically have a high school degree. Then they go into the field and they train for, I believe it's like a 6 months to a year program. And they learn how to deal with programming of hearing aids. So they are more focused on hearing aid and treatment of a hearing loss. And then we have audiology assistants who they usually go to school for 6 years. So their requirement is still a high school degree, but it's a 6 years extra program that they learn basically how to assist the doctor of audiology. So the field is growing as we were talking. Year by year, we're getting bigger because the more science comes up, the more treatment comes up. You need to actually be able to have this, other people help you out if you really want to be conducive to outcome.
Wow. And I love that because so many of us, you would imagine an audiologist is just a doctor of hearing or ears of some sort, but I love that there's so many different categories.
Right. And you know what? On top of that, it's an ENT, ear, nose, and throat doctors who are physicians. And physicians usually deal with either medication or if it's an infection or some sort of a surgery. So a lot of times if we have some sort of an audiological disorder, like let's say I have ringing in my ears or suddenly, I don't know if I hear so well anymore, the first place that people think of is, okay, I'm going to call my ENT. But the problem is that the ENT doesn't, when they look into the ear with the otoscope, that device that we put into patients' ear canals to look in, they actually see the ear canal and the eardrum. They don't know what is happening behind the eardrum. So basically, audiologists are the eyes and ears behind the eardrum. So when you go to the ENT, basically the ENT has to send you to an audiologist to figure out what's going on if they can't visualize anything wrong. So this is so interesting that, you know what, there were times that audiology was so dependent on ENT, and now the coin has flipped. ENT is so dependent on audiologists because they don't know what is happening, and we need to tell them based on the equipment that we have and the testing that we do that what is happening behind the eardrum all the way to the brain, which the sound goes for interpretation.
And it seems like the ENT should have an audiologist in their staff. Like, it would make so much more sense.
Most of the time they actually do.
Oh,
Most of
okay.
the time they do, but you know what? Especially in state of California, because I practice in California, a law came out that the ENT and audiologists, because they sell hearing aids, they cannot be interdependent because it could be considered as a kickback to each other. If you pay me, I pay you type of a thing. So that's why a law came out that they have to be two independent business and they could be using a location together.
Oh, that makes sense.
But yes, it makes perfect sense. And a lot of ENT offices actually do hire an audiologist as a staff. So this way, they are a part of the corporation.
Yeah, that makes a lot of sense. Now, let's talk about the most common audiologic kind of issues, right, with autism, because I know that so many of our kiddos, mine included, has had issues with covering his ears or can hear things that are like, I always find it to be like a superhero strength. It's like, I remember all of a sudden he kept saying, baby's crying. And I'm like, well, what are you talking about? And 4 doors down, like in a housing tract, not like an apartment. I'm talking like regular houses, like in a cul-de-sac. He could hear 4 doors down the baby crying. I could not hear that. Like, I had to go outside and really strain to be like, oh, maybe. He knew exactly. And he'd say, baby's crying. Or he could hear a siren like so far away. And I would eventually hear it, but he would hear it. I swear it felt like almost 30 seconds to a minute before I did. And it's fascinating to me. It's like I call it a superhero strength. I don't necessarily know I'd want that superhero strength, but when we're talking about those on the spectrum, let's talk about what are some of the issues, or I know those are some of them.
Those are some of them. That's the most important one that you are talking about, because a lot of them have hypersensitivity to sound. It's like they hear way better than we hear. And I tried to actually find the research proving that they have better hearing than we do. But unfortunately, I couldn't find any research showing that the threshold of hearing, which is basically the lowest sensitivity to sound in ASD, is any different than normal people. But it seems like because they are so much in tune with their senses, because they have so much sensory input going in, and their brain is so much sharper in grasping all of these things, it seems like they just know things better. They understand it better. That seems to be, to me, one of the issues, because we cannot prove that the threshold is any better. It seems like they are just hypersensitive to sound. So that's one of the first things. Now, with that hypersensitivity to sound becomes an issue which we call hyperacusis. So hyperacusis is when the sensitivity to sound becomes too much. So a sound which is normal to you and I becomes overwhelming for them. And actually, hyperacusis is the major issue that when we see an ASD child or kiddo, that's the first thing that they complain about. It's like, it's too much. It's like, I hear everything and it's just uncontrollably loud. And that has to do with all the sensory issues. Remember, in ASD, one thing which shows is that the hypothalamus and the brain doesn't process sound the same way. So the filters that we have, which we filter unimportant stuff out of the background, for them doesn't exist. So everything goes in. It's multisensory, oversensory. And that's one of the reasons that we think that they have that sensitivity to sound. So Besides hyperacusis, what we see is tinnitus, which is the fancy name for ringing in their ears. There are a lot of times that when they go to sleep, you know what, you see that they're uncomfortable, they're holding their head. It's like, and when you keep on asking the question, they talk about there is a sound, there is a hum, or there is like something in the background. So tinnitus is very common. And actually the research shows, and I wrote these numbers because I'm awful with numbers, it shows that 31% of mostly Asperger kids have tinnitus. So 35% in Asperger kiddos, we have tinnitus. 69% of Asperger, they have hyperacusis. And 31% of the population have both of them. And this number in just a general ASD becomes to be 18%.
Wow.
So it's like, it's just unbelievable. These are large numbers. And I'm going to actually get into more things that it works. You know, we have more issues that we have audiological issues with the thing. But I have to tell you this. Audiology has always taken a back seat to ASD because everybody has always thought about ASD as this general global problem that we need to take care of this. Nobody have actually thought about, okay, in order to take care of this big issue, let's take care of the individual issues, which is wrong. Let's address the individual issues, and then from bottom up approach, let's do it, and maybe we make a big impact on the top here. And that's what usually audiologists have taken a back seat. You don't see them, and you see PT in front, you see a speech in front, you see a behavioral therapist in front, but usually don't see audiologists in the front, which this is where everything is changing. The new audiologists which are coming out, we all are trying to educate as many people as we can about all these issues with ASD that could be addressed on a basic issues, which is going to make such a big change on the top issues that we have. So going back now to more issues that we have, one of them is auditory processing disorder, or what we call central auditory processing disorder, like CAPD and APD, which is basically what the brain does with what we hear. We know that autism, one of the main issues that we have is communication problem of the kiddos, right? But when we talk about communication, they have to be able to hear us in order to communicate with us back. They need to hear, they need to process what you ask them to do or what you requested them to do or what, and they need to be able to verbalize it back, right? So if we have a kiddo who hears you per se, the loudness is good enough, the message goes through, but the message doesn't get processed, or the message is too complicated to get processed, or the message is in an environment of a background noise which is too degraded to get processed, how do we expect them to answer to us, right? So that becomes a communication breakdown and then a tantrum, and we think about, okay, you know what, this is just another tantrum of ASD, and nobody talks about, oh, this could be issue of the child or the kiddo not processing the information, right? So that's another thing. The other issue, audiological issue, could be the memory, working memory issues, because working memory basically is how much you hear, how much you hold in your executive function in the frontal lobe, and then how much you can process and give back. So it becomes a part of APD again, right? But most likely it happens to, you say something and ask them, okay, what did I tell you? And it's hard for them to repeat back to you. So that becomes a working memory issue. What else can I tell you issues we have? Maybe processing of the information. Again, that falls into the category of auditory processing disorder, which, you know what, they categorize the information in the wrong categories. So again, if we want to talk about globally, what are the issues that we have? It's hyperacusis, sound sensitivity, central auditory processing disorder, or APD. We have tinnitus, which is another major issue. We have two new disorders which are coming out, and I am excited to talk about them. There is one called phonophobia, which is basically being scared of sound. In
Wow.
some of the ASD children, we never paid attention to that. One sound comes and they always gives them scared. It's like,
So my son is babies crying and dogs barking, and that is very common across the board with ASD. It seems that if you have sensitivities, it's the babies crying and the dogs barking. And I swear he has to have high motivation to get through that. It's much better now, but oh my goodness, like it was almost his whole life of after getting diagnosed. And
wow.
so
And
it
does it matter how loud it is, Christine? Or if it's even far away, it gives you
even
that
far away, like
same emotion, right?
And
Same.
so I can be like, I think I was joking before the call, but or the interview today about PTSD, but I'm serious. I think I even have PTSD when babies are crying now or a dog barks, because even when he's not with me, like I'm so sensitive to knowing, oh, baby crying, I better get out of here now, because it can literally cause him to freak out, have a meltdown, and lose it. Not so much anymore. And now he can talk through it. We're doing better. I'm curious what your take is on this. I ended up buying baby dolls that cried really loud, and like you'd have to soothe them, and then they'd laugh, and then they give you a bottle and all that stuff. They make baby dolls now that look really real, so much better than when I was a kid. But so I bought 2 baby dolls for him that sounded very real. They feel real. They look real. And when I first gave them to him a little over a year ago, he did not like them whatsoever. And now they're on his bed. And I know it sounds weird to have an 8-year-old son with 2 baby dolls on his bed, but I purposely put them there because I tell him, like, oh, the babies are crying. You better give them their bottle. Like, oh, you better do this. And now he's doing this thing where he hears a baby crying. He immediately does this, but I almost feel like it's like a reaction now. And he'll first do this. And then I'm like, dude, like, what's going on? He goes, he just did this a couple weekends ago, cracked me up. I don't know where he got this from. Baby has pee-pee diaper, change the diaper. But I also wonder, I wonder if, like, now that he has some experience, even though it's not a real baby, but it's his version of that. I'm not having a kid for him to get, practice over it, right? Nor do I want to do any babysitting. So I think this is about as close as we're going to get. But I think having this scene, okay, it's a baby crying, we give a bottle, we can change the diaper, we can rock them, they're tired, they're hungry, whatever. He can visualize now what that baby's crying, because before, I don't know, I can only guess, I don't know. Same thing with the dog. We bought a dog 3 years ago because he was definitely afraid of dogs. And I was like, well, what do you do when someone's definitely afraid of something? You got to get him through it. The first 2+ years, he did not, it was like, he wanted to be on that side. And I remember starting to feel really bad. I had people going, I'll take the dog. I'm like, no, you won't. We will get through this. And, but he, little by little, like, he's so much better. Like, now he helps feed, like, put her food in the bowl. He'll give her a treat. He'll literally walk up and kind of like pet her and be like, hi, Bella, I love you. Mwah, goodbye. Have a good day. And he'll walk away. Like, he has like this, I get you're here. There's your space. Here's my space. Now, here's the most fascinating thing of the whole thing. We'll be out now and he sees a dog and he doesn't freak out. And like, he might say like, Bella barking. He calls every dog Bella now because that's our dog's name. But he literally used to, I would be afraid. He would like run and take off or like start violently getting upset. Now it's like, you can, it's just a dog, no big deal. No big deal, he'll say. So, but it's fascinating. Like, those are the 2 things I'm doing, trying to get through it. What's your take on that for families that are?
Number one, I think you're a behaviorist on your own. Good job, bravo. You dove into desensitizing him by actually bringing the dog home. Well done. You know what? I have always been a big fan of you and the way you treat Jack. And you know what? I've followed you for so many years, and that's why I'm here, because I'm a big fan of you and Jack's both and the improvements you have made. But yes, that's absolutely right. You did it correct, and that's exactly the best definition of phonophobia, because phonophobia, it's not a matter of how loud the sound is. Rather, it's what kind of a sound is. And that kind of sound increases all the limbic system in me. It's all flight or fight mode. And either I got to react or run away, the way you exactly said it. So that's the best example of phonophobia. Now, another example of the next disorder which just got introduced is misophonia. Misophonia is actually basically annoyance to one kind of a sound, but it's like, think about chewing. So misophonia got very famous when Kelly Ripa started talking to how annoying she reacts to her husband's chewing. So when Kelly Ripa started talking to it about it, everybody started, oh, what's misophonia? Let me Google misophonia. Let's see what it is. So suddenly misophonia became this big of a deal, whereas we knew misophonia what it was. So misophonia is especially one kind of a sound, and it's not only the sound. Sometimes it actually has even the visual input. If they see someone just chewing, even if it's no sound, they just get overexcited about it, and here goes the limbic system.
Is that like the nails on the chalkboard? Like I feel like
That too, exactly.
I go automatically. I'm like, ah.
Exactly. That emotional reaction to it is like, oh, I can't tolerate it.
Yeah.
That's exactly it. So that's misophonia, which in a lot of people are different sounds. Not necessarily it's chewing. As you say, it's like the thing on a chalk, or for me it's like this ticking of the clipboards when when we are typing things. If there, I can never be in a room that 10 other people are typing, because it's just, for me, it's like it's like you're pulling nails out. It's like, or pulling my hair. It's just very uncomfortable. So any type of a discomfort or emotional reaction to what kind of a sound, that is a misophonia. So in ASD children, we're starting to see all these things. As our knowledge of audiology is expanding, the more we get to know. And ASD is not what it used to be 10, 15 years ago. Now we are, because there are so many other children, so many kiddos, now we have some who are actually aging, so we can actually do longitudinal studies, so we can learn more about how do they age, how do they learn as they age, how do they cope. So this is why we're growing. Our field is growing, but the most important part is that the growing field, we need to actually start putting output more, right? We need to get involved more. We need to be talking about it more. I don't find audiologists who talk about these things a lot. You know what? We have big centers who talk about, like maybe USC or UCLA in California. But you know what? I think we need to find more individual private practitioners who are willing to take these kiddos on and start treatments, right? Start doing things on the base level so we can actually make an improvement in their life, their global life.
Well, we talked about, treating. How do you evaluate a kid or an adult with autism?
Ooh, wow. It depends on their functionality, to be honest with you. The most important part is how verbal they are, how good can they behavioral responses we can get. So if it's, usually in Asperger, they're high functioning, it's easier to test. So we can just play audiometry, or have them, press this button if you hear it, do a couple of testing, a couple of times as a trial, and then they get the idea, they do it. If there are people we cannot get them involved into the behavioral testing that we do. We have a lot of testing, we call them electrophysiological tests, which means we basically do the test through the equipment without requiring their behavioral responses. So I give you one example is tympanometry, which is the movement of tympanic membrane. One thing which I forgot to tell you is that research shows that about 7.5% of population of ASD has some sort of a mild hearing loss. So doing annual audiograms, it's very good. Just the way that we take care of their teeth every 6 months, we got to do one annual test to make sure that their hearing is okay too. So we do tympanograms, we do otoacoustic emissions, which is OAE, and that's the response of the outer hair cells of cochlea to how much sound bounces back from the cochlea rather than goes through. Then we have, if it's a kiddo and we want to see how their threshold of hearing is, we can do auditory brainstem response. And then auditory brainstem response, we have of two kinds. We could do it with clicks and we could do with speech. So Nina Kraus is the main doctor who's doing a lot of speech ABRs, and she has wonderful testing which shows results in ASD children. So there are a lot of stuff that we could do. We are not so much limited the way we used to be because our equipment and our knowledge of autism has improved. The most important thing that I sort of find in my office is establishing a relationship. If the mom and dad come in and the kiddo is in, and the office doesn't look like a generic medical office, and it looks like a home that you walk into or an apartment that you walk into, they don't get hypersensitive about it. They don't get tensed. And then we always, usually the first session, it's all about getting to know the kiddo.
Mhm.
But we're not doing anything. We're just sitting, while we're in the same room, so they have that proximity, because some of them have issues with proximity. Once they learn all that, the second time, pretty much you can get whatever results you want. But if we can't do that, then we go all to the electrophysiological testing that we want to do.
Now, is there solutions and treatments for these? Like I never say it right. Because I used to think it was called tinnitus, but it's called tinnitus.
Tinnitus.
Yeah.
Tinnitus?
And I used to call it tinnitus, and I was like, is it like
Well, tinnitus is good too, like potato, but I always explain the issue with tinnitus is itis in Greek. So all of these words have Greek background, right? So itis in Greek is for some sort of an infection. Okay, so usually bronchitis, laryngitis, you know what? All of these things are some sort of an infection, and that's why tinnitus, it's not an infection. So it's the correct one if you want to actually dive into it, is tinnitus. But potato, we can just get
No,
rolling.
I'm glad. I want to learn to say it right. So, how are there treatments for this? I mean, and how do you test even for somebody like my son who might not be able to tell you that there's ringing in the ears? Is there a machine or something that tells you that they have it?
So there are two kinds. We have spontaneous tinnitus, which means you can actually, somebody from outside could hear the tinnitus. Okay. So that without any equipment, you can actually put your ear close to somebody's ear and you hear it. So that's the first thing we do. But a lot of tinnitus patients and phonophobia and misophonia, we actually use questionnaires that the parents and the significant other or family members fill out. And based on those questionnaires and their behavioral responses, then we can tell if this patient is suffering from tinnitus or not. Thus far, we don't have any testing for tinnitus because tinnitus is in somebody's head and there's no way we can visualize it, unfortunately. Functional MRI has started to be, but it's very expensive at this point. They're still being used mostly in research, but it shows that if we do a functional MRI from kiddos who have tinnitus, or even normal people who have tinnitus, we actually see the areas of the brain which are overacting and they're all red. So, but currently in private practices, no, we just concentrate on questionnaires.
And so I know we're going to do a part 2, and we're going to probably dive into, the different treatments and solutions, because I know that's what families want to know. Okay, now this part 1, everybody, so you guys understand, this is us just giving the background of like, okay, we need to find an audiologist. This is what audiologists do. This is what's going on most likely for our kiddos. Part 2, so guys, keep a lookout for that. Part 2 is going to really dive into the solutions and the treatments, because there are some, which I get very excited about, because as you said, they didn't even know there were certain conditions up until not that long ago about, these 2 new conditions that, yeah, they existed. They just didn't have a label for it. So,
right.
That makes me excited in the sense of, okay, that means that there's going to be help, because now it's not like, well, we don't know what that is. Yes, we get it, but there's no real label. Now there's a real label. When there's a real label, there's real treatments and solutions. And that's what I love.
I agree with you. And that's what I love too, because you know what? In order to be able to help someone, especially with ASD, we have to look beyond ASD to see the patients, to see the person, to see the family. And that's when we actually start treating. What I am most excited is there was a time that ASD was this big global thing that, everybody thought there's nothing to be done. Now we have all these hopes and information that we know there are things to be done. We can do things. Let's fix things.
I love that. So I can't wait to have you back, because that whole talk, just so everybody knows, that whole talk is going to be about solutions and treatments of having, whether it be auditory processing issues, whether it be other things going on. Dr. Cohen's coming back, and she's going to give us some great tips, solutions, and how, if you are in California, where to find her. So for right now, where do people find, do you have a website? Can we share that with everybody?
We have a website. Our website is called hearinglossolutions.com. My office is in Sherman Oaks, California. The phone number is 818-989-9001. I would love to see patients, but mostly my job at this point is education, trying to get the word out there for all the parents who are looking for information because they don't know where to start. So hopefully soon we're going to have a whole group of people who can actually help so many people. But right now I'm just excited to inform everyone about everything.
I love it. Well, thank you so much for being here, Dr. Cohen. I can't wait to have you back because we really need the solutions and the treatments that are out there. And to everybody watching, thank you guys for, remembering, as Dr. Cohen said, there's so much hope out there and we're here. And don't forget, hope is our middle name here at Autism Hope Alliance. So until next time, bye guys.
Bye-bye.